healthcare special as a form of redistribution or as a form of solidarity between members in a society. And one of the things, one of the primary theses of this paper is that there is a right to adequate health care. And it can be defined operationally, which is a real challenge for scholars and policymakers in this area. It's the right to access, to equal access to that middle-class health care, to the sort of health care that is available to those in the middle of society. But Professor Elhaig realizes that we could today easily spend 100% of our GNP on health care without running out of services that would provide some positive health benefit to some patient. So thus, trade-offs must be made, and thus the moral principle that we owe health care to each other, or that we can move that amount of health care provided to the middle class, is not in fact absolute. It has to be traded off. Both within health care, we have to trade off on which priorities for spending given a limited budget, but also we have to trade off between healthcare and other consumption decisions to decide how much of a healthcare budget we want to have, given that there are other values in life. And Professor Elhaig says in this paper again, we could accept the proposition that the greatest good in life is health. So put everything else secondary, but still conclude that purchasing more health care is less effective than funding nutritious food, safe housing, environmental protection, college tuition, or even simply distributing cash. And in 1994, there was already a really clear empirical basis for this theory called the social determinants of health. The idea that our health outcomes are determined more by the lifestyles we live, the neighborhoods we live in, the security we enjoy, the diets we consume, that our health is more often and larger determined by those factors than it is by the health care we receive itself. And that evidence has just gotten stronger and clearer in the 20 years since this paper. It has been 20 years, Professor Elhaig. This is supposed to be a roast, right? And I'm not just going to read from Professor Elhaig's papers all day, but this is one more passage. He says, we value many things besides health. The cost of devoting resources to healthcare is often expressed monetarily in those graphs I started with. But that's merely a shorthand for the value we could derive from alternative uses of those resources. It makes no sense to spend money to live longer at the sacrifice of those things that make life worth living. In the end, we all die. The question is which allocation of resources will allow the best things of life. I think this reflects some of the best of Professor Elhaig's scholarly instincts, moving between rather technical analyses that you'll see throughout this paper and others into the details of antitrust law, but also remaining sort of philosophically ambitious and philosophically grounded to pay attention to what's really at stake. So when we think about that growth of health spending as a part of the larger economy, we know that the bulk of the long-term rise has resulted from the healthcare system's use of new medical services that were made possible by technological advances. Here we're talking about drugs, devices, imaging, other tests that are really driving healthcare growth. We know all about the demographic changes, such as the baby boomers getting older, but they're not the explanation for that consistent growth for the last 50 years that's predicted to go forward. So they create the bumps along the way, but the sort of inexorable drive to more healthcare spending, most analysts understood, is largely driven by these technological advances. And when you think about technological advances, that is driven by our patent system, our antitrust system, and the incentives we create elsewhere in the healthcare economy. But strikingly, when you look at what is actually consumed in this system, less than half of it can we say that we have evidence that it actually works, that it actually makes us at all healthier. That's a pretty low bar to cross, because conceptually, the proof that it makes us at all healthier. You might want to set a higher bar that says that it makes us more healthy than the next best alternative, or it makes us next best healthcare alternative, or that it makes us more healthy than anything else we could do with the money and these social determinants. But here, even in the low bar of any proof that it works at all, for most healthcare spending, we just don't know. And so that really compels questions about how we can regulate in this area to make the healthcare spending more efficient. And so that brings me to this 1996 paper of Professor Elhaeg's, where he actually takes that question on directly and says, could we create a regulatory structure that has a specific goal of looking at health technology and deciding whether it should be allowed on the market? Or they might have other more precise levers, whether it should be reimbursed by Medicare, or whether it should be allowed in certain clinical settings. But the most fundamental threshold question is whether it should be allowed on the market at all. So you can imagine a regulator being created with this task. It's not exactly the task the FDA has, by the way. The FDA's statutory mandate is whether something is safe and effective, and it's not whether it's cost effective at all. So Professor Elhaeg's view on this is that he doubts that technology regulation can do much about the cost escalation problem. The technology we get reflects the incentive structures for using it. There's a lot in this paper that explains why it's difficult to do technology assessment. In part, it's because of the heterogeneity of a population. Technology might be good for one patient in one clinical setting, but bad for another patient in another clinical setting. So there's heterogeneity. There's also very deep philosophical problems in trying to figure out how much a year of additional life is worth, and how much is worth for one person compared to another. So these deep and difficult problems have largely been punted in our healthcare reform efforts. We've largely put them off to the market to solve. And the primary way that the market is trying to solve this problem is by asking the patient to do some of that hard work, to do that difficult task of selecting whether healthcare is worth its price, whether healthcare should be consumed. This graph displays the growth in healthcare plans in the employer-sponsored health insurance market, which is most of the health insurance market in the United States. This is the growth. The top line shows all firms, the growth of them having plans with at least a $1,000 deductible. And you can see just from 2006 to 2012, it's more than doubled in the number of firms, going from 16% to 49% that have these higher deductible plans. Now, even $1,000 is a pretty low threshold for deductible health plans. Federal law allows them to be 6 times higher than that. But even below the $1,000 threshold, we're seeing fewer and fewer firms remaining there, which means patients are more and more asked at the point of consumption to take out their wallets and make the decision as to whether a fraction of the cost of that consumption is worthwhile, and if not, to decline to consume. So in a sense, we've pushed out the difficult decisions that Professor Elhaeg prefigured, and more pushed them out into millions of micro-level decisions by individuals deciding whether to consume. And the way cost sharing works is it takes, the cost of a procedure and splits it and says, patient, you have an obligation for some amount. Insurer, I'll pay the rest if you decide to do it. And this is really old-fashioned economic theory, that if we give patients skin in the game, then sometimes they will assess whether the benefits from the consumption will be outweighed by the cost that's imposed on them. And it's important to emphasize that cost sharing really has 2 different functions. One function is the obvious one, that for any health care that is consumed, the insurer just bears a smaller proportion of it. So if it's a $10,000 procedure and you can make the patient pay $1,000, then from the insurer's point of view, it's now only a $9,000 procedure. They've saved on the margin whenever health care is consumed. But the second effect here on the right is actually to change how much health care is consumed and which health care is consumed. I call the first one a distributional effect. It distributes the cost between the insurer and the patient. The second one's a behavioral effect. It's designed to change which healthcare is consumed and how much. And so the idea is that of 9 instances of healthcare consumption, we actually try to make 3 of them disappear, for example, because the patient realizes that, gosh, maybe that cost share isn't worth the price. Maybe I'll move to a less expensive form of care or other mechanisms. Now, there are limits to cost sharing as a rationing mechanism. And the big one comes from our recognition that most of health insurance, most of health consumption is actually consumed at the very top by a very small number of people that are consuming very large amounts in a given year. These are people that have chronic illnesses. These are people that have other severe illnesses like cancer or need heart stents replaced, implanted. So 5% of our population in the United States is consuming half of all our health care in a given year. And they're spending on average about $55,000 in that year. Not out of pocket, that's the total spending for that patient. And so when you think about how cost sharing is going to work in this domain when we're in these high dollar figures, if we really want to sort of reduce health consumption, we have to be thinking about how it works in this high-end range where most health dollars are actually spent. And I think that's something that's often overlooked by policymakers in this area. So the other difficulty with cost sharing is that in fact we have to cap how much exposure an individual has. Because individuals have limited wealth. And we can't, insurance will fail to serve its purpose of guaranteeing access to care and protection from risk if patients are have so little insurance that when they approach a big healthcare decision, they're unable to access the care they want. We then have a problem of false negatives, where individuals decline very good, high-value healthcare simply because they can't afford to meet the out-of-pocket obligations. So accordingly, health insurance beneficiaries and their agents, which are often employers, will provide health insurance plans that cap their out-of-pocket obligations. And this is from a survey of all employer-sponsored health insurers, a sample of them in the United States. What you can see is in 59% of the workplaces, the employee is exposed to less than $3,000 of out-of-pocket spending in a year. So that's their first deductible usually, which is often about $1,000, and then it's 20% of the consumption up to that, beyond that first $1,000 until you reach a $3,000 total. So for 59% of the people, once they've spent $3,000, they're back in a realm of full insurance. They have no cost-sharing obligations at all. And you can see even above that, only 11% of the population is in truly higher deductible health plans at $5,000 or more. So for an example of how this works, if we want to really understand what cost sharing does, you have to think about it in practice. And this is how you would reach that $3,000 deductible. First, at the beginning of the year, you would have tests and preliminary procedures and perhaps a visit to the hospital, and it would exhaust your $1,000 deductible. In that deductible range, you enjoy no insurance at all, really. You have 100% skin in the game. But in the next range, you have some insurance, this range where you're paying 20% of, or 18% is the most common copay of the health care consumption. So that ends up being 18% of the next $11,000 is where you're in this middle range of full insurance. Once you've surpassed that $11,000 of health spending, you reach the $3,000 cap. So that means that health cost sharing as a allocation mechanism, as a rationing mechanism, which originally motivated this analysis, is sort of done for the patients by the time they reach $12,000 in total spending. That's a lot of money, but it also, patients spending less than that are not accounting for most of the money that's spent in the United States health care system. So cost sharing then is so when we think about this $3,000 cap, is that a lot of money or is it not enough money? And this is data from the U.S. Census Bureau for income. I've put the income in the United States in 5 quintiles. I'm sorry if the text is a little small. But you can see in the bottom quintile, these are people earning up to about $20,000 a year. For them, a typical cost-sharing maximum of $3,000 is 30% of their income. On the other hand, if you look at the richest quintile in the United States, that $3,000 of cost-sharing exposure in a year is only 2% of their entire income at the middle of the quintile. In fact, I had to censor this for visual purposes, because if I put the top 5% of American earners, it wouldn't even fit on this graph, of course. So you can see in the middle, for median Americans, that typical cost-sharing maximum of $3,000 is about 6% of their income. So that graph I showed you, the very different relationships between cost sharing and income, has also been seen with surveys of how people actually spend in healthcare. We know the wealthy spend about less than 1% of their income. The people in the top quintile spend less than 1% of their income on out-of-pocket healthcare, while the poorest are spending 11 times as much as a percentage. So that creates two domains for us to think about. And the first domain is those people that are overinsured. The people that have more insurance than they really need in order for insurance to serve its purpose of protecting us from risk, its purpose of guaranteeing our access to care. For these individuals, the cost-sharing obligation is probably too low because they could bear more risk and thus be empowered as rationers in this healthcare system longer for a larger portion of the healthcare consumption decisions. At the same time, there's likely a range of people that are underinsured, those that have too much exposure to risk, and they find themselves in bankruptcies and foreclosures and denying needed care. And so this is a fundamental problem, I think, in our current healthcare system that prevents cost sharing from being a complete solution to the allocated decision making that began our talk. So in the overinsured area, we have this domain of moral hazard, this domain where people are making healthcare consumptions. At the point of consumption, they're deciding whether to take the patented drug rather than the generic, but they don't face that price distinction at all because they enjoy full insurance beyond that range. On the other hand, we have those below that are underinsured that are experiencing bankruptcies. This is a study by Elizabeth Warren and a team that looked at people going through bankruptcies and found that half of them were associated with medical bills or medical injuries. Some of my own, I hit page down instead of next. That's dangerous. In fact, most of these slides I wasn't even planning on showing you. Okay, I'm back. Similarly, for foreclosure, in some of my own research, I surveyed people going through home foreclosure and found that many of them were actually driven by medical problems. So what we know then is that cost sharing is now effective in this green domain. I have patient income on the vertical axis, the cost of the procedure or the treatment on the horizontal axis. And we know cost sharing sort of works for people that are relatively wealthy, but only for the low-cost care, the first $12,000 of care. It doesn't work at all for the very poor people. That's why it doesn't go all the way down to the axis, because they can't really bear much cost at all. Nor does it really work going out to the right for the very highly costly procedures. A heart stent implant that costs $50,000, or a patented cancer drug that costs $80,000. In those domains, cost sharing is really not a very effective solution. So my research has been working on ways to solve this problem, and I've been thinking about two different mechanisms that we could use in sort of future rounds of healthcare reform, or perhaps through market-based solutions right now. And the first one is in this domain. And the idea is to scale cost-sharing obligations to income, so that individuals have the amount of skin in the game that they can bear. And the difficulty, of course, is figuring out how much they can bear, but I suggest that in the employer-sponsored health insurance market, the individual's wages is a pretty good proxy to the amount of risk they can bear. And that information is readily available to the person that buys the insurance for them, their employer. So here's a nice coincidence that we've evolved a healthcare system where the one person in society that knows how much you're paid also is the one that's providing your insurance. Simply transferring that information from one function to the other can provide greater insurance. So that line is diagonal, meaning that as long as you can bear risk with higher income, you can also have cost sharing involved for higher cost procedures. Beyond that line, though, the worry is that if we imposed additional cost sharing on you, if we asked you to pay a $5,000 deductible or a $15,000 deductible, that would deny your access to care and defeat the purpose of health insurance. So in that domain, I've suggested a second possible solution, which is called the split benefit, where we could actually pay health insurance benefits as cash to patients and allow them in that way to decide whether to consume. I'll talk about each of these just for a couple of minutes. The first one is scaled cost sharing. This paper is coming out next year. And the notion I've already suggested is insurance is provided by employers. Employers know how much wages they pay. They can scale cost-sharing obligations accordingly. And so, for example, you might suppose it becomes a 7% out-of-pocket annual maximum. That your employer says, your obligation, I see you make $100,000 a year, then your maximum exposure this year is 7%. But on the other hand, your assistant who makes $50,000 a year her maximum out-of-pocket exposure is $3,500. On the other hand, the vice president of the company who's making $200,000 a year, his out-of-pocket exposure, her out-of-pocket exposure would be $14,000. So each individual gets a report, as part of their benefits package that scales their cost-sharing obligations to their income. Strikingly, there seems to be no example of a current employer actually doing this in the United States. The closest is one firm, Pitney Bowes, that has a few different tiers where managers seem to have higher cost-sharing obligations than lower-level workers. But that reflects the insight. We do see more often about 10% of employers are scaling insurance premiums to income. And that serves a useful distributional function, but it doesn't solve this behavioral modification function that is cost-sharing. The example here is focused on scaling the maximum out-of-pocket exposure in a given year, but you could also scale deductibles so that maybe people enter that realm leave the realm of no insurance and go into the realm of some insurance later. You could scale their co-pays, so instead of everyone paying 18%, some pay 25%, some pay less, and even the amount you owe at the doctor's office could likewise be scaled. We now have the technology to do this that we maybe didn't even have 15 years ago, so that doctors' offices can consult in real time, an online database for each patient to see what their obligation is. And we already do this for other purposes. So the idea is that this reform would be potentially cost savings on net. It could actually bend that cost curve down by providing more skin in the game in that realm where the most health expenditures occur at the high end. For those expenditures that are, over the $12,000 where the current caps often put people. So we would put more skin in the game for the wealthier employees. You might have noticed that, our distribution of incomes is not linear. That it starts curving up pretty sharply at the distribution of incomes. We have people getting really, really wealthy, but there's kind of a floor on how little you can earn. Zero does that at the very least. And so there's actually more room for scaling upwards than scaling downwards, which suggests that the reform may be asymmetric, that it may save more money than it costs, even if at the same time we're expanding insurance for poorer workers. This also arguably creates a larger bargaining surplus between the employer and the employee. You can imagine if an employer offered pants as an employee benefit. Everyone gets a free pair of pants for working here. Well, if the pants were one size fits all, people would value those pants not very much. But if the pants were scaled so that each person gets the size of pants they need, individuals would value those pants more. They could actually use them. And so the idea is that when you scale a benefit, assuming you can do so with low administrative costs, you can actually get a higher perceived value by the recipients along the entire domain, and thus have a greater bargaining surplus. Because most health insurance is actually understood to be foregone wages. Individuals get health insurance rather than wage compensation. And so the value of that insurance can be more or less attractive. And there's also a lot of evidence that providing greater health insurance could actually increase productivity for lower paid workers, that reduce absenteeism and that sort of thing when people are on the job. How much time do I have? 3 minutes. So there's a lot of potential legal problems that I develop in this paper about the Affordable Care Act actually capping cost sharing, but there's still room, I argue, for scaling underneath that cap. That the tax code actually, by making health insurance non-taxable, discourages higher paid employees from taking on more skin in the game. But some recent reforms like health savings accounts and the tax on Cadillac plans is pushing down that distortion, creating more room. The IRS actually has a policy that prohibits discrimination by compensation levels, but it's designed not to protect higher paid employees, it's designed to protect lower paid employees. So I argue that would not be prohibitive to this proposal. In fact, could be argued to require it because the current flat cost-sharing maximums tend to discriminate against the poorer employees because it prevents them from taking advantage of those health insurance benefits to the same rate that the higher paid employees do. So there's actually potential here for the IRS rulemakers to nudge employers in this direction. There's also potentially an agency problem that the wealthier employees are setting healthcare policies for the firm and may, in the short run, prefer non-scaled benefits if they don't think that they can cash out the savings and wages instead. So the other solution to the split benefit, I'm going to set that aside for today, but it ultimately involves paying people cash on the possibility that they will decline to consume. Say, here's a portion of your health insurance. If you want to consume this expensive, unproven care, take the money and pay for it, and we'll pay the remainder. We'll sort of match it. For a lot of people, that when I've presented this idea, strikes them as viscerally quite wrong, paying people not to consume health care. And that's essentially what a cost sharing does too. If we increase cost sharing on wealthier people, you're saying you have to spend your own money if you want health care. And so the big objection that I want to develop in the Tulsa Law Review paper is this question: is it wrong to use incentives to discourage consumption while nonetheless preserving choice? And that really, it's only plausibly true, even if we ignore society's interests, it's only plausibly true if the healthcare consumption would be good for the patient. It would actually be something that would improve their well-being. But as a policymaker, we actually don't know whether any individual healthcare consumption would be good for the patient. Professor Elhague, just one final quote from his in this 1994 article, says, "Paternalism perhaps most accurately explain what actually motivates policymakers to refuse to simply redistribute cash. The poor, many believe, would irrationally spend money on the wrong things." And that's the main objection I get to these sorts of proposals, is that if you put skin in the game, people will stop consuming. You're actually paying them to be sick. And so I want to take that head on in this paper and develop really 7 reasons why we might not suppose that health care consumption is in a patient's individual interest, unless we have specific, credible evidence that it is. And the first is the physician's conflicts of interest. Physicians are in fee-for-service relationships, they have relationships with industry, they're often self-referrers, and I've reviewed the evidence here and shown that in another paper and shown that these relationships actually seem to bias their prescribing behavior. So the mere evidence that we have a prescription is subject to question. We also know from I've already shown you that most care prescriptions in the United States are not supported by evidence. There have been no randomized studies to show that they work. When based on the evidence, we also know that it's often false. A review of all the articles published in the New England Journal of Medicine, for example, for the last 10 years, that checked whether the article proved a previous clinical practice or disproved the previous clinical practice, found that about half the time the new articles were disproving prior clinical practices. Things we thought that worked were discovered in the New England Journal of Medicine that actually didn't work. So that's a review of every article published, just one example of how the evidence can be false. In the United States, about 80% of the clinical trials of drugs and devices are funded by the drug and device industry themselves, and those studies have been shown to be 7 times more likely to produce favorable results. So even when we think we know that something works, we sometimes later find that it doesn't. There are also rampant publication biases. Journals are much more likely to publish an article if it shows that something works. At the same time, that buries a lot of articles that show that it doesn't work. There's also been a very large difficulty in replicating prior research. There's a systematic problem. Even when we have true evidence that something works, the effect is often quite marginal, meaning that we've proven that a statistically significant number of patients get better, but often that'll be as small as 1 in 100 patients that take the drug. And often in the realm of 1 in 2 or 300 patients are there very serious side effects. So the benefit for any individual patient is like rolling a 100-sided die and hoping that patient is the one that on the margin gets better. In the future, through genotyping of medicine, we might get better at predicting whether you will be the patient that benefit from this drug, but at this point, it's largely, it seems to be luck. Finally, not finally, but getting closer, nobody's really paying attention to cost in these high consumption ranges, so we can't really infer from the consumption decision that this will increase the marginal utility to the patient because of the moral hazard problem I suggested. And then, as we already heard, that other spending can promote health too. There might be other ways for the patient to promote their own well-being. So maybe we should defer to them if they do if they do choose to spend money elsewise. And finally, as we suggested, that other goals may trump health and may value other things. So all these together, I'd suggest basically a presumption against consumption. That if an individual chooses to consume otherwise, and we give them the option, they choose to spend their money in a different way, we should probably reject that choice, unless we should probably not reject that decision or assume that they've somehow failed simply because they've declined health care. Thank you very much.